And then I will. Okay, so today we have Rianne Booker. She's an oncology and palliative care nurse practitioner with over 20 years of experience in cancer nursing. She works at the Tom Baker Center in Calgary, Alberta. Her clinical and research interests include integration of palliative care in oncology, sexual health and cancer, advanced care planning, medical assistance in dying, cannabis and cancer, global oncology, and health equity. She's a PhD candidate in the School of Nursing at the University of Victoria, and the focus of her PhD research is going to be on the integration of supportive and palliative care for patients with blood cancers. So thank you so much for being here today, Rianne. We're so happy to have you, and I will hand it over to you.
Well, thanks so much for having me, and hi, everyone. Thanks for being here. I'm just going to share my screen here and get the slides up. And maybe if you can just give me a thumbs up if you can see the slides. Perfect. Excellent. So yeah, thank you again. And I'll just preface this by saying no need to take notes. I'm going to send these slides to Erin, and she can send the slides out to you. And also feel free to email me with any questions you may have if you don't feel comfortable asking them today, or if you don't get a chance to ask them today. So conflict of interest, I don't receive any funding from any drug companies or pharmaceutical industry or anything like that. I have received some funding for my PhD research through government scholarship and nonprofit organizations. So of course, I have to say that this presentation is for educational purposes and not a substitute for medical advice. So please check with your healthcare provider before you make any changes to your treatment or your medications. So today I want to talk about the impact of pancreatic cancer and its treatment on sexuality and intimacy, and talk about some strategies to help manage and optimize sexual health and intimacy after a cancer diagnosis. So years ago, when I first started working in Edmonton at the Cancer Center, I worked with patients who had prostate cancer and testicular cancer. And I found that we always asked those patients about sexual function and relationship issues and things like that. We didn't ask that in the other clinics I worked in. So the other clinics at the time were blood cancer clinics. And I started asking the questions of those patients too, and found that they also had similar concerns to the patients with prostate and testicular cancer. And throughout the past 20 years or so, I've found that it doesn't really matter the type of cancer or the type of treatment. Changes with sexual function and relationships can be very prominent and very common, irrespective of the type of cancer. We at the Tom Baker Cancer Center in Calgary, myself along with a couple of psychologists, set up a pilot sexual health clinic that we ran for about 3 years before the funding ran out. And we saw patients with all different types of diagnoses. And so it's not just limited to things you might intuitively think. So breast cancer, prostate cancer, testicular, really this is something that a cancer diagnosis and a chronic illness of any kind can really impact sexual function and intimacy. And when I first started to kind of delve into sexuality after a cancer diagnosis, I realized there's a lot of different things that affect sexuality. So things that kind of precede the cancer diagnosis and kind of aren't really necessarily related to the cancer diagnosis. Things like previous experience, a partner, culture, religion, different medical conditions that the person may have. And then of course, the things that we do with the treatment and the cancer management. And really, we know that anything that impacts vascular function, so blood flow, hormone function, nerve function, any of the treatments that we provide can impact sexual function that way. And again, to make the point that some of these changes can happen because of cancer in the treatment, but some of these changes can happen as we age normally. So there can be changes in hormone levels and different things like that that are part of normal aging. But certainly we know that cancer and treatment can make those changes happen quicker, and often they can be more severe. So when you think about sexuality across the illness trajectory, I did a study a few years ago, and I remember a patient saying to me, maybe it's not the best time to talk about somebody's sex life right after the cancer diagnosis, because it's very overwhelming and you're dealing with a lot of information at that time. But it is important, if we're thinking about things like fertility preservation and different considerations like that, to bring up sexuality and intimacy earlier in the disease trajectory and not wait until the very later stages of treatment, because a lot of these issues, if we catch them early, they can be managed and managed well. During treatment, again, a lot of people might think, well, well, I'm getting chemo or radiation. It's not a time that I want to be necessarily involved in sexual activity. But again, there's some practical considerations. So over the years, I've had patients ask, well, is it safe to have sexual activity? What if my platelets are low? What if my neutrophils are low? And so there's some considerations to think about in that regard. And then where we saw most of the patients coming to our sexual health clinic was when their cancer treatment had finished and they were in that recovery and survivorship phase, which again is probably when people are starting to think about getting back to day-to-day life and things like that. And so there's more time to think about sexual function and things like that. But at the same time, as I mentioned, it's easier if we start to talk about these concerns early on. Because we can prevent some of the changes from happening, or if we catch things early, they're easier to manage. And then again, intuitively, some people might think that nobody is thinking about sexual activity or intimacy at advanced, where there's advanced disease or end of life. But again, over the years, I've seen patients that have said, and their partners, that they really desire intimacy. And it may not be sexual intercourse, but physical and emotional intimacy can remain very, very important, even towards end of life. And just to say, I did a presentation on sexual health at a hospice here in Calgary a few years ago. And what prompted them to ask me to speak was that one of their staff had gone in to see a patient in one of the rooms, and all the rooms in the hospice are private. And they walked in on a couple that was engaging in some activity, and they thought, oh my goodness, wow, do we need to have socks on the door handles or some kind of sign to indicate that there's sexual activity happening? But really, it just makes the point that people do desire that closeness and that physical closeness, even at end of life. It still remains important. So this is a busy slide, but this just to make the point that we do a lot of different things with cancer treatment. And sometimes it's the cancer itself, depending on where it is. And again, if it's impacting blood flow, nerve function, hormone function, the cancer itself can adversely impact sexual function. But then certainly the treatments that we give, surgery, if it damages nerves or blood vessels, radiation can damage nerves and blood vessels, chemotherapy so things like oxaliplatin or any of the platin types of drugs can cause nerve dysfunction. And then hormone therapy, that would be more for things like breast cancer and prostate cancers. We're not using that as much or at all really in the pancreatic treatment. But immunotherapy, we're starting to use in a lot of different types of cancers. And we don't really know yet the impact of immuno-oncology or immunotherapy because those medications are still quite new. So there's a bunch of physical changes that can happen for sure for females. And in our clinic, the biggest ones we would see would be potentially early menopause, but kind of across the board, we saw vulvar and vaginal dryness that then could make intercourse quite painful and difficult. And then psychosocial, so things like body image, self-esteem, worries about cancer recurrence or progression, depression, anxiety, and relationship difficulties are all really quite common as well, and they can really impact intimacy and sexuality. And for males, again, similarly, if we have any of the treatments that we provide, they can alter a bunch of different types of sexual function. And in our clinic, the most common things we would see would be changes with erectile function. So difficulty getting or maintaining erections, or even the firmness of erections can change. And then again, for the men, psychosocial changes are also really important. So body image, self-esteem, depression, anxiety, relationship challenges are all quite common. And thinking about desire, and again, this is something that can change just naturally as we age, that, we think about young men and women where that desire might be spontaneous. So there's just kind of these spontaneous thoughts about sex or sexual activity that are definitely mediated by hormones, but a lot of different things as well. So psychosocial stressors and things like that. And so Masters and Johnson they developed this sexual response cycle many years ago. That's more or less a linear process. So desire followed by excitement, arousal, orgasm. But we know that from years of study with sexual health that it's not quite linear like that. It's is a lot more complicated, and that you can still have a satisfying and pleasurable sexual experience, even in the absence of that spontaneous sexual drive. So you may not have those thoughts about sexual activity necessarily, but perhaps if you get into a situation where you're, maybe there's some cuddling or some massage and things like that, then desire can come afterwards. So you don't need to necessarily have that spontaneous desire to go on to have a sexually satisfying experience. And as I mentioned, the things that we would see most common in our clinic, and I'll say that this happens even in the absence of cancer and treatment, many of these changes will happen with normal menopause for women, is, changes definitely with the vulvovaginal tissues. So we can see definitely genital dryness, decreased lubrication, which can lead to painful sexual activity and bleeding even. And then you can imagine if there's painful activity or painful sexual intercourse, that can then impact orgasm and desire. So if it's a painful experience, your brain kind of tells you, I don't know if I want to participate in this again because this was really uncomfortable or not very fun at all. And so that can become a bit of a vicious cycle. And we can see some structural changes even with the vulvovaginal tissues as well. So there can be some physical changes with the anatomy of the vulvar tissues. But again, some of these changes, if we catch them early, we can prevent them from becoming worse. And as I said, a lot of these things can happen with normal aging. And this is where it's important to talk to your family doctor or a gynecologist even about the potential use of even local vaginal estrogen to help prevent some of these changes. And for men, again, changes in erectile function are very, very common. So there can be difficulty achieving erections, difficulty maintaining erections, and insufficient firmness for penetrative intercourse, and that can be vaginal or anal intercourse. Recognizing that you need about a 30% more firm erection for anal intercourse, loss of early morning erections or nighttime erections, and I would say again that a lot of this happens with normal aging. So men over the age of 40, about half or 50% of men over the age of 40 have some degree of erectile difficulties, and that can be for a variety of different reasons. So if there's things like diabetes or cardiovascular disease, all of that can impact erectile function. A lot of different medications can impact erectile function, but certainly we know that when we throw in chemotherapy to the mix or radiation therapy, that can also lead to challenges with erections. So we know, again, like I said, if there's nerve damage to the blood vessels, changes in hormones, and then psychological changes as well. And for many men, it's a combination of all these things. So radiation, surgery, chemo, they can all cause changes to the vasculature, the blood vessels, and the nerves. And that can lead to challenges. And again, if there's been 1 or 2 episodes where there's challenges with erectile function, that can then psychologically lead to more potential challenges in the future. So again, it's really important to try to intervene as early as possible if we can, to try to help prevent some of these changes, and also just for the awareness that some of these changes may happen with normal aging or with treatment. Changes with ejaculation, we don't see as much outside of things like treatment for prostate cancer. So it wouldn't be as common with pancreatic cancer, but it still can happen. Again, it can also happen with normal aging. So definitely if there's nerve dysfunction from chemotherapy, radiation, or surgery, there can be issues with delayed or premature ejaculation. More so, this would be with pelvic radiation. So there can be almost like an epididymitis or irritation of the epididymis or the urethra for men that typically would resolve within several months of finishing radiation, but there can be pain with ejaculation temporarily after radiation. And then for men who have prostate cancer treatment, we wouldn't expect to see this as much with pancreatic, but there can be changes with how much ejaculate comes out. And again, certain types of cancer, testicular cancer and prostate cancer, there's something called retrograde ejaculation, where the ejaculate actually goes backwards into the bladder, and that's because of damage to a valve at the top of the urethra. But again, we wouldn't expect to see those latter two with pancreatic cancer as much. That's more so with prostate cancer. And same with climacturia. That would be urine leakage at time of ejaculation. And again, that's because of nerve dysfunction and damage from typically from radiation and surgery that we would use for prostate cancer surgery. So again, not expecting to see that as much with pancreatic. And then for men and women, we can see changes in orgasm. Again, this can be because of nerve dysfunction most often. And then again, the psychosocial component as well. So if sexual activity is painful, or if it's not pleasurable, if it's stressful, that can really impact orgasmic function. So most often we would see people talk about decreased intensity of orgasms or absent orgasms, rarely painful orgasms, and sometimes complete loss of orgasms. So again, most often because of nerve damage, be it from chemo, radiation, or surgery, and also the psychosocial component as well. Fertility, this could be its own entire talk. And I know that this isn't always top of mind for a lot of patients, but again, if it is a concern, it's something that ideally we address before treatment starts. And that's because a lot of the treatments that we provide can cause temporary or permanent infertility. So ideally, we like to have these discussions and the opportunity for patients to see a fertility specialist before treatment starts. That's not always practical. Sometimes we have to start treatment immediately because it's a life or death situation. There's also some other practical things as well. We need a platelet count to be higher than 50 to be able to do an egg harvest and things like that. So sometimes even though we like to get people in to see fertility specialists, it's not always practical. And it can be costly as well. So, there's costs for in vitro fertilization. There's costs for even semen, sperm cryopreservation, so freezing semen. There's an upfront cost, and then there's an annual fee to store the sperm. So these can be expensive. There's different organizations that can offer some financial assistance, but that is a bit limited. And again, you really do need that window of time to preserve fertility before treatment starts. And as I said, body image can be a concern for both men and women. And, we can see, of course, things like scarring from surgery, hair loss from chemo. We can see weight changes. So that can be weight gain or weight loss because of the medications and treatment. There can be skin changes from radiation, so almost like a bad sunburn and even blistering that can happen. And it was really telling to me when we did a study on sexual health, and this was for patients with blood cancers having bone marrow transplants. But the men in the study, all of the men in the study had significant concerns with their body image, which was eye-opening to me because I incorrectly assumed that this would be a bigger concern for women going through treatment, but it was just as much a concern for men. And so this one patient, he said, the first time he looked in the mirror, he literally fell to his knees sobbing because he didn't recognize the person that he saw. And he said, I'm trying to fight off tears now talking about it. I've mourned the loss of who I was. I was stronger physically. Now I'd say I'm 90% of what I used to be. I've got a much bigger heart. Some say it's the girl blood that makes me cry so easily. So he had a transplant from a female donor. That's what he means by girl blood. And then another patient talked about, losing all of her hair because of the chemo and, having all these tubes and different things. And then her husband made a comment that, it's like you have a Brazilian. And he said, that's quite funny and fun. And so they were trying to find the silver lining. But, the changes with body image can be profound and they can be persistent as well, even after treatment's finished. And this, again, a huge focus of the talk today being relationship changes. So it doesn't matter if it's a long-term relationship, a long-term marriage, or maybe perhaps somebody was newly dating when the cancer diagnosis hit, or maybe somebody was single and now they're trying to get into the dating world again after their cancer treatment. So it's challenging for anybody really in the relationship category, I would say. Trying to navigate existing relationships, particularly if communication has been a challenge. And then if you're dating, when do you disclose that history of cancer and things like that? They can all be very challenging. We know that there's not a lot of research on the impact of cancer treatment on partners. But we do know that partners can be fearful of causing pain or discomfort during sexual activity. So that can cause them to pull away and not want to engage in sexual activity. Partners might feel unwanted or rejected because there's decreased activity, especially if that's been a prominent part of the relationship for a long time, and then suddenly it changes because of treatment. I remember seeing a patient with breast cancer, and the treatment we were giving her was causing profound changes in her vulvovaginal tissues and decreased interest in sexual activity. And when I was explaining that to her and asking if that'd been a concern, you could see her husband, and the light bulb just went on, and he didn't realize that treatment could impact sexual function and intimacy. And he had felt completely rejected from her, and it was really impacting the relationship. And they weren't aware of these changes potentially happening before treatment started. It can also be difficult too if the partner has to shift from being a partner or spouse to being a caregiver. So you have to change hats, and then switching back to being a partner again can be very difficult to have that transition. And then again, some partners might be fearful about losing their spouse or significant other, so they might pull back again as a way of protecting themselves from potential loss. So all of these changes can happen, and we don't, my bias is that we don't do enough for caregivers in the cancer care system. We have a lot of resources and supports for patients, especially during cancer treatment, but when cancer treatment is finished, sometimes there's a bit of a gap there in the supports that we provide. And certainly I would say even throughout the treatment trajectory, we don't do enough for caregivers. So I think it's really great that this organization is focusing on providing resources and supports for caregivers as well. We have data to show that having a caregiver or spouse throughout cancer treatment can actually impact survival. So people with a caregiver and with a healthy relationship, we see improved outcomes. So to me, that tells us we need to be providing more supports for caregivers for sure. Again, we don't have a lot of information on sexual and gender minorities. We know that about 10% of the population or so identifies as LGBTQ, and these populations have lower rates of early detection and access to screening and lack of resources tailored to their needs. There was a national study done in the US of oncologists looking at their attitudes and beliefs about sexual and gender minority care. And everyone recognized that it was important, but most of the oncologists didn't have the training to be able to identify the unique needs. And we talk about equity in healthcare, not equality. So I use the example that, we want everyone to have equitable care. And if we said to a patient who was blind, well, we're just going to give you these patient handouts, they're the same that we give to everyone else. So you're getting the same treatment. It's not really the equitable type of care we want to provide, because that blind patient, it's not helpful for them to have a printed handout. So we need to learn more about the unique needs of patients who are identifying as sexual and gender minorities, and then tailor our care to their needs. And I would say that's an area that is starting to gain some recognition, but definitely needs a lot more work. And again, as I mentioned, there's considerations when people are unwell or in hospitals. So you think about our hospital beds, they're single beds. We don't have, wouldn't it be great if we had double beds? And I'm not talking about necessarily sexual activity, but even just to cuddle or to lay with your partner in a bed when they're feeling sick and in hospital. And then again, this is my palliative care background coming in here, but managing symptoms. So of course, if somebody is feeling unwell with pain or shortness of breath can be difficult to engage in kissing even. But if somebody is having nausea, vomiting, diarrhea, uncontrolled pain, that can really impact their desire and their willingness and their ability to participate in sexual activity. And if you again think about the hospital environment, it's very, we're terrible in terms of privacy. It's not a very inviting environment. There can be different types of tubes and things like that that can be difficult. And sometimes partners can be concerned about, pulling out a tube by accident or something like that. And so I think, again, as healthcare providers, there's more we could do to help preserve intimacy. And I'm not always here talking about physical necessarily, but again, that emotional intimacy and that closeness that people desire, especially when they're feeling unwell and at end of life. As I mentioned, we had a clinic at our cancer center, and my belief is that a lot of these changes with sexual function and intimacy, they really are biopsychosocial in nature. So, there's that psychosocial component, the relationship component, and then there definitely are some physiologic or biologic changes that can happen because of the cancer and treatment. So our approach to managing sexual health concerns and intimacy really has to have this biopsychosocial approach. And so in our clinic, we had myself as a nurse practitioner, we had gynecologists that would rotate through the clinic as well. And we had psychologists that were at the clinic, every single clinic we had, so that we were really addressing things from a holistic perspective. Again, this is just another diagram just showing that, we can't just treat the biologic component, because there's the psychological component, there's the interpersonal with relationship component, there's sociocultural concerns as well, religious beliefs, cultural values and norms and things. And then of course the cancer related treatment or cancer and treatment related issues. So it really has to have this, holistic approach to management of the concerns. So when we think again about interventions, and you'll hear me say it throughout, it's not always about returning to sexual intercourse as the be all end all goal, but improving communication. I think from our side of things, just informing patients and their caregivers about what to expect in terms of changes with relationships and intimacy is a huge part of what we could do to make this a little bit easier to manage. Counseling, I think, is always a really important component of management. And then supporting the partner and caregiver to make sure that they can remain in that partner role and they don't have to take on as much of that caregiver role. So that's where we could provide different assistance, things like home care supports and things, so the partner can stay in the partner role. And then there's lots of different devices and non-invasive approaches we can take. And then there's, of course, as I mentioned, managing treatment-related symptoms. And then there's more specific interventions that are a little more invasive that I'll get into in a minute here. And we always were quite, I would say, liberal with referring people to other specialists. So urologists, gynecologists, the hormone doctors, the endocrinologists, and pelvic floor physiotherapists. We had a good network of people we referred to with special interest and expertise in sexual health. And it might surprise people that urologists and gynecologists don't get a lot of sexual health training in their residencies and their training programs. Gynecologists, I remember a sexual health gynecologist from the United States saying in his whole residency program, he had 4 hours of sexual health training. So he went on to specialize in sexual health, but a lot of gynecologists and urologists don't have that training. And certainly family physicians as well, unless they identify that that's an area of interest. A lot of them don't have that training or expertise either. The communication piece, again, it's really important. We had some questions about, if the partner is feeling upset or angry or, pushing the person away, really talking openly about the emotional and physical feelings that are going on. This is, again, I think where counseling can really help, especially if communication has been a struggle in the past. My belief is that everyone can benefit from more communication skills. And so this can be something that can be very helpful. Planning ahead, that might mean taking anti-nausea medications or pain medications before engaging in sexual activity, recognizing that pain medications can take 30 to 60 minutes to kick in, and then taking things slow and just really being patient with each other. One of the psychologists that I worked with at the cancer center here in Calgary, they have different questions that patients and partners can talk about with each other. So things like, what do we do if one partner gets aroused and the other one doesn't? And what about exploring other ways to achieve orgasms? So does it have to be sexual intercourse? Could it be oral sex or manual stimulation? What about using things like sex toys and vibrators? And that might be something completely new to the couple. And so that might take a little bit of time and communication around, is this safe? Is this okay? Do we feel okay with this? And then really talking to each other about what feels okay and what doesn't. If there are surgical scars or the skin after radiation can be very sensitive, sometimes it can be numb. Sometimes it can be painful even to light touch. And so talking to each other about what feels good and what doesn't becomes very important. Different positions. This is a great question that somebody asked, sent in. So what positions are the best for sexual activity? And I would say it varies depending on the type of cancer, where things were, the type of treatment, the type of discomforts and pain that can happen with sexual activity. So, trying different things, using pillows as supports, maybe doing things like standing up or, using different kinds of supports in different positions. And a lot of the people we saw in our clinic, they weren't familiar with even changing to different positions. And I think that that's quite common, that a lot of people were familiar with missionary position sex or even woman on top sex. But some of the different positions were a bit new. And this takes a bit of trial and error, just trying to figure out what feels okay and what doesn't. And again, that's where that communication piece is really key, talking to each other about what works and what doesn't feel good and what does feel good. And it can take some practice for sure, which might feel strange, especially if it's been a long-term relationship where those things hadn't been a concern in the past. And then improving intimacy. And I always joke and say, this top image here where they're in the bathtubs, that's an ad for Cialis. And I always think they could improve their intimacy if they were in the same bathtub, not in separate bathtubs. So even taking baths together, engaging in some sensual massage, taking sexual intercourse off the table, because there can be a lot of pressure on both partners. If it's very painful for the partner, for one partner or the other, it might take some time to help manage and treat the pain first, before there can be sexual intercourse. Similarly, with erectile dysfunction concerns, there's a lot of pressure often to engage in sexual activity, sexual intercourse, and that can put so much pressure on the person that they can, psych themselves out of actually having erections. So I would say take the pressure off, engage different types of intimacy. So emotional, sensual, reserving the sexual piece until both partners are comfortable. Things like having baths or dancing or massage, engaging in outer course or other course and different types of non-penetrative activity. And then there's special exercises like sensate focus, where that would be a trained psychologist who could help the couple go through. And it's usually done over a period of 6 to 8 weeks. And the first couple of weeks, there's no touching of intimate areas. It's just talking to each other about, what feels good in the body and what doesn't, and then eventually progressing to touching intimate areas. This is again an opportunity to engage in discussion about if there's scars, if there's skin changes because of radiation and things, talking about what doesn't feel good and just exploring that over time. And then improving desire, again, that awareness that just because you don't feel in the mood at the time, if you start to engage in some intimate massage maybe, or some cuddling, that desire may come still. Counseling can be really important here as well. Mindfulness-based meditation. And again, this is where psychologists have skills in helping patients with this particular activity. Improving erectile function, we have a lot of different options for this. And I would say that the first thing we need to do is figure out the reasons why this is happening. And then we start with the least invasive options. So there's a whole bunch of different options here. This one here is called the Elator. It's a custom-made device that helps to put the penis in an upright position. Because it's custom-made, it's fairly expensive. It's about $350 US. It won't make the penis hard. It just helps to put it in the upright position, so to speak. So we haven't really used that much in our clinics. Probably the most common thing that we've done in our clinic is tried the phosphodiesterase type 5 inhibitors. So drugs like Viagra, Cialis, Levitra. They all work very similarly. They increase blood flow into the penis that leads to an erection. They need to be taken before sexual activity. So some people find that difficult because it removes a bit of the spontaneity, because you have to think about taking the pill before sexual activity. Tadalafil or Cialis now has a 5 milligram dosing as opposed to the 10 or 20 milligrams. So it's a lower dose that patients can take every day. And that allows a steady amount of the drug to be in their system. So it does allow for more spontaneity. You don't have to think about taking that pill beforehand. If there is bad blood flow or nerve damage, these medications won't work. So again, this is why it's really important to figure out what the reason is for the erectile function issues. The biggest difference between these medications, I would say, is that tadalafil or Cialis is called the weekender. It's got a longer half-life, so that drug stays around in the system a bit longer. That doesn't mean that somebody is in the upright position all weekend. It just means that there's opportunity then to engage in sexual activity because that medication is in their system. I remember the first prescription for Viagra I wrote many, many years ago. And the patient and his wife were so excited. They had a nice fancy dinner, they did some dancing, and then they both fell asleep. And when they woke up in the morning, the drug was out of the male system, so they weren't able to engage in sexual activity. So, trying, they all work similarly. So if one doesn't work, sometimes we'll try a different one. Avanafil is not available yet in Canada. And what else do I say about these? The only big red flag or contraindication with these is that if someone's taking nitroglycerin for chest pain, taking one of these medications at the same time can cause their blood pressure to become really, really low. Taking regular blood pressure medication is fine, but nitroglycerin in particular can cause the blood pressure to be super low. So that would be one to avoid. And then the other options, again, we taught patients in our clinic how to do the intracavernosal injection therapy. So if there's nerve damage and that's the reason for the erectile challenges, the medications don't usually work. Injecting directly into the penis, and it sounds scary, but it's a tiny, tiny needle, like a diabetic needle. And that can result in erections in 90% of people having challenges with this nerve-induced erectile dysfunction. So it can be very effective. Transurethral therapy, that would be where there's a medication that goes into the urethra and then it gets absorbed into the tissues in the penis, and that can lead to an erection. That is effective about 20 to 40% of the time. And then the vacuum erection devices can be very effective, but you really need a good quality device. So something that's got pretty good suction. And how these devices work is they pump blood into the penis, and then you use something like a constriction ring at the base of the penis to trap blood in the penis. And then that can allow for sexual activity. And they do work. They can be upwards of 80% plus effective, but you do need a good quality device. And then the penile implants are also quite effective, but that's a surgical procedure. So that would be reserved usually for, somebody who's tried all these other strategies and they're not working. And then we could look for something like this. And this is where there is an implant placed either, so that there's an implant placed in the penis with a reservoir that's either in the abdomen or in the scrotum. And that allows the man to pump the reservoir, and fluid goes into the tube that's placed in the penis, and that causes a temporary erection. And then when sexual activity is done, or when they don't want the erection anymore, it just drains back into the reservoir. Alternatively, there can be a semi-malleable rod that's placed in the penis, and that can allow for the penis to be, placed into an upright position to allow for intercourse to happen. And those are very effective, the implants, in the neighborhood of 95 to 100%, but they are surgical procedures. So they do come with some risks, and again, would be reserved for, somebody who's tried all the other less invasive approaches. Orgasmic function for males and females, we don't have very many studies on this. So some strategies, definitely counseling, I would say mindfulness-based meditation. Penile vibratory stimulation has been studied in prostate cancer. The jury is still out here. We don't have great evidence to say that it works or doesn't. That would be using a vibrator to cause vibrations on the penis to help improve orgasmic function. Some medications, again, the trials have not been very promising. So again, I would say that counseling is probably the best bet for this. And then for females, again, too, we want to figure out the reason for the sexual concerns. And counseling, again, would always be a mainstay of therapy. And then looking at the use of regular moisturizers and lubricants. So just like you would moisturize the skin on your face, moisturizing the vaginal tissues, especially after menopause, where after menopause, the estrogen in the vagina and vulvar tissues is depleted, and the tissues can become very frail and irritated, prone to bleeding, and that can make the sexual activity very painful. And so using moisturizers, and these are available over the counter, things like Replens, Repagyne, Gynotrove, Zestica, but they need to be used at least 2 to 3 times per week and for at least 3 months to see optimal benefit. You can even use things like vitamin E capsules, where you puncture the vitamin E capsule and squeeze the oil out and rub that into the vulvar tissues and into the vagina. And then lubricants would be used for sexual activity. So the moisturizers, regular use, even if there's no sexual activity, but lubricants to be used for sexual activity, or even things like pelvic exams, which can be very painful, speculum exams and things like that to do pap tests and stuff. So water and silicone based are the safest and best to use. The water-based lubricants don't last as long. The silicone-based lubricants definitely last longer, but they can stain sheets. So again, it's finding what works for you and trying to find products that don't have a lot of preservatives or additives, because those can also irritate the vaginal tissues. So those are just examples. And vaginal dilation, historically, this has been something that's been reserved for female patients getting pelvic radiation. But we found also that in patients who've not had sexual activity for a long time, or for whom the menopausal type changes are really profound, or even just very dry vaginas, allowing the woman to do gentle vaginal dilation can help restore confidence and can help get those tissues a little more elastic and a little more ready for intercourse. And so the dilators we give out at the Cancer Center are these ones on the left. They're hard, kind of plasticky. They're not very tapered, but they are free of charge at the cancer. Most cancer centers will have them. Alternatively, patients can purchase, these ones are medical grade silicone. They're tapered. You can see they come in different sizes. And they're a little more pliable and a little bit easier for some patients to use. There's instructions how to use a vaginal dilator. I like these instructions from the Cancer Center in New York City. And then vibrators too can allow for, again, some sexual play, some sexual activity. There was a study done a number of years ago, and the thought was that if you if you use a vibrator, you can improve blood flow to the tissues. That might help improve healing to the tissues, especially after pelvic radiation. That study closed early because everybody in the intervention arm was having better results, and the person doing the randomizing ended up putting people more into the treatment group. So they had to close the study early, unfortunately. But the use of vibrators can help males and females. So if there's nerve dysfunction or difficulties with orgasm, just playing around to the extent that people feel comfortable, can be helpful. And there's even one called a Vibrator. It can be used for men, even with a flaccid or semi-erect penis. The vibrations can then lead to orgasm. So men often don't know, but you don't need an erection to have orgasm. You can still have ejaculation and orgasm, even in the absence of an erection. You just need that stimulation. So be it partner stimulation or with a vibrator, you can still go on to have orgasm. You probably don't need this one here. This one's gold plated and retails for about $17,000. I'm not sure who would need a gold plated vibrator, but there you have it. Again, pelvic floor physiotherapy after pelvic radiation, after surgery, even after significant hormone changes for women, pelvic floor physio can be very helpful. And it's really important to have a physiotherapist who's specialized in the pelvic floor area, because there's different assessments and interventions that they're able to provide. Hormone use, we had a great question about the use of testosterone after pancreatic cancer. And I would say right now there's no evidence to suggest that pancreatic cancer is affected by hormone use. So we know breast and prostate for sure. Some types of breast and prostate cancers are influenced by hormones. Some types of gynecological cancers and brain tumors. But so far there's no evidence that pancreatic cancer would be affected by hormone use. So that means for women, you can talk to your doctor about using estrogen, especially if we've pushed you into early menopause. But even with natural menopause, using local vaginal estrogen can help restore the health of the vaginal tissues. We say that you really do need to treat the opening of the vagina, the clitoral area and the vulvar tissues, and then inside the vagina. So this is an example of Vagifem. It's a tablet that's got estrogen in it. It's great. I've seen patients who have beautiful looking vaginas, the tissue is healthy in the vagina inside, but the opening of the vagina is quite dry, and the vulvar tissues on the outside are quite dry because those areas aren't getting any estrogen. If you use that tablet that goes, it treats the upper part of the vagina great, but the bottom part, the opening, it doesn't get treated. So, using a very low dose estrogen cream and applying to all those areas can really help restore the health of the vaginal tissues and make intercourse more comfortable. We have different options here in Canada now. So this is an intravaginal DHEA that can be used. Ospemifem is kind of like a tamoxifen almost. It's a selective estrogen receptor modulator that can help with vulvovaginal dryness. And Imvexxy is a low-dose estradiol insert. I can't remember which ad this came from, but I really did not like the marketing that they're showing these dried, dying flowers to represent the dry vagina. And I thought this must have been a man that came up with this. No offense to the men listening, but it just seemed, a bit offensive to me that, you're likening the dry vagina to these dry, dying flowers. But to make the point that there are different options for hormone therapy if we've pushed someone into menopause, which we often do, or even if it's just natural menopause. Laser therapy, you may have heard about the Mona Lisa therapy. So how this works is it kind of burns off the upper layer of the vaginal tissues, and then those tissues can regrow. And the thought is that there'll be more vascularization and the moisture will return to the vagina. So far, the evidence would say this is not something to do. There can actually be injuries and more damage caused by the lasers. So, and they're profoundly expensive, thousands of dollars per year at least. So this one for sure right now we're saying hold off. There's better ways to manage vulvovaginal dryness than the laser therapy. Testosterone replacement again can be injections, patches, or gels, and there's no overt contraindications for pancreatic cancer. If there's history of blood clots, hormone therapy is something we want to be careful about because hormone therapy can increase the risk of blood clots. But again, that's something that we can manage and we can watch for. And then just some caution about herbal or natural products. This is, again, Memorial Sloan Kettering Cancer Center in the US, and they've got a great website where you can punch in the name of any herbal product, and it will tell you what's in it, what the uses are, and if there's any warnings or contraindications for the type of cancer someone has and the type of treatment they're on. And I remember at the World Meeting on Sexual Medicine a few years ago, they had studied, the so-called gas station Viagra, where people can buy it over the counter kind of thing. And what they found was a lot of the products that people were buying online or at these different places that were not licensed to sell these, products, they found that some of the products contained some of the PDE5 inhibitors, some contained multiple PDE5 inhibitors, some contained none, some contained ink toner cartridge. So just to say that be careful where you're getting these kinds of products from and make sure there's no contraindications with the chemo you're on and the type of cancer you have. Safer sex, again, I'm almost done here. I think this is almost my last slide here, but just to say that we want people to be cautious. There's not been any great studies about having sexual activity with someone who's on active chemotherapy. We know it's possible that there can be some minute amounts of chemo that are in semen and vaginal secretions. What that means for a partner, the risk is probably very, very low to a partner, but we do say it's recommended to use condoms or dental dams for 2 to 3 days after having received chemo. Where that becomes a little more challenging is if somebody's on oral chemo and they're on it daily for months at a time. But again, we feel that the risk would probably be very low for partners. When patients have platelets that are low, and again, those are your blood clotters, there's potential for increased bleeding and bruising, so avoiding really rough sexual activity. And I've had patients ask about things like flogging and whipping and different things. So you want to be careful about bleeding and bruising. And when the neutrophils especially are low, there can be a potential for increased infection. So things like anal intercourse or, again, really rough intercourse could be risky in terms of increasing the risk of infection. We always encourage people, of course, to practice safe sex. especially if they don't know their partner's background or if there is concerns about sexually transmitted infections. So just to close, I would say preserving intimacy is really key. It does not need to be sexual intercourse. This was my colleague who created this diagram for prostate cancer, but I would say it applies to really any type of cancer. So we can preserve relational intimacy, physical affection and physical intimacy that's intercourse independent. So you don't need to be thinking about sexual intercourse necessarily. If we do get to the stage where we're thinking about intercourse, we'd want to make sure that, we're helping with erectile function, helping with vaginal symptoms for sure. And then, of course, there's all these other activities that don't involve sexual intercourse that people can engage in that can be very satisfying as well. So this is something that ideally healthcare providers should talk with patients before treatment starts. I don't think that this should be on the patients to have to bring these questions up. But this is an opportunity, I guess, some sample questions, and this is for a type of blood cancer, but again, it could apply to any type of cancer. So, how might the treatment affect sexual activity? Is it safe? Are there any precautions that need to be observed? And then again, talking about the different things that might come up like vaginal dryness or erectile function issues. So just to say, it's very common for changes in sexuality and intimacy to happen after cancer treatment. There's lots of different things we can do to help improve sexual function and intimacy. There's really no right amount of desire or perfect relationship or normal sex life. It really depends on the patient and their partner. And there's lots of different things that we can do. So talk to your healthcare provider to find out what options might be best. If something isn't working, we can try something else. But keep talking to your partner especially, and don't give up. Lots of different resources and websites. It's good to go directly to these websites rather than typing sex into a Google search, because you can end up with some interesting things. And then there's some LGBTQ resources as well. And again, I'm happy to send these slides so that you can access those resources as you like. So happy, I went a little longer than 45 minutes, I'm sorry, and happy to answer. It's a lot of info, but happy to answer questions, or again, if you feel more comfortable emailing questions, I'm happy to answer those as well. One thing
oh, sorry.
Oh, go ahead, Erin. Yeah.
Oh, I was just going to say that was a fantastic presentation, Rianne. Thank you so much. It's, a topic that can be so hard to talk about sometimes.
Oh,
and
yes.
I think you made it very digestible and not an uncomfortable topic at all. And yeah, thank you so much for doing that. And sorry, go ahead and
Well, I was just going to say, it can be a difficult topic to talk about. And I think, as healthcare providers, we're sometimes shy to ask as well, but we have no problems asking people about their bowel movements, the shape, the color, the consistency. But this piece, the sexual relationships and intimacy, is a very huge part of quality of life for a lot of people. Again, for some people, it's not a concern, and that's totally okay. But I do feel like there's a lot we can do to help improve this aspect. One thing I didn't mention is some people after radiation to the pelvis, women especially, will feel like their partner is bumping up against, if it's penetrative intercourse, they can feel like their partner is bumping up against something. If there's been hysterectomy or that too, the vagina can be shortened. And so sometimes there can be what's called collision dyspareunia, or pain with deep penetration. And in the past, we've had people, use towels or things like that to control the depth of penetration. There's now something called the O-ring, and it's a series of these stretchy silicone type rings that can be placed on the base of the penis, and that you can stack them so that controls the depth of penetration, so that the male partner doesn't penetrate as deeply. And the feedback from male patients is they actually like this because it's quite snug on the penis. It's quite a pleasurable sensation for them. But then it can control that depth of penetration, which for some women can be quite painful. So yeah, that's an option as well. It's called the O-nut, and I think I have it in one of the slides. So yeah, there's lots of different things, lots of different devices and things. If people have questions about specific things like that, I'm happy to send info. So yeah.
That's great. Thank you so much, Rianne. Does anybody have any questions? Feel free to either unmute yourself or type them in the chat.
And if no one has questions, I would ask as well, have your healthcare providers ever talked about this with you? Have they provided you information about what to watch for, or offered any suggestions for how to maintain relationship intimacy and things like that? And you don't have to answer if you don't feel comfortable.
No problem. Well, like Rian said, if you do think of any questions, or again, if you're just maybe not comfortable asking them here, you can either send them to Rian, or you can send them along to me, and I'm happy to pass them along to Rian. But yeah, thank you so much. This was a fantastic presentation. Again, super informative on things that you don't always get, that you might not be comfortable asking, or that you might not be given in a typical appointment. So I think that was really great. We're so glad that you were here. Rianne is going to be back in October to do a talk on cannabis and cancer, which will be really interesting as well. So we're looking forward to that. If nobody has any questions, then we're good to go ahead and let everybody enjoy their weekend. Thank you so much again, Rianne. That was fantastic.
Yeah, Erin, I'll just quickly run through the questions that were sent in just to say, so
Yeah.
what's the most comfortable position? So again, there was that one slide from the American Cancer Society with different positions. I would say just try different positions out to see what's best. One question was, what if you don't want to have sex? I would say that is perfectly fine. But again, that's where that communication piece with the partner becomes important. So again, it doesn't have to be sexual intercourse, but perhaps there's ways to maintain emotional intimacy and even some component of physical intimacy that is not sexual intercourse. Taking testosterone safe? Yes, it is. With pancreatic cancer, there's no evidence to say that it's not safe. Achieving intimacy with a partner without having sex. I hope we talked about that a little bit. So there's different things you can do that don't involve sexual intercourse. And then if there's partner responses about the diagnosis and pushing the other person away, I would say the biggest thing with that would be communication and counseling. So getting to a place where it's safe, where both people can share their feelings, and it might be individual counseling to start, and then couples counseling at some point. But really, your feelings are valid. Both people in that relationship have valid feelings and needs, and trying to come to a place where both people are getting their needs met. And I think that that's best achieved by counseling, and then looking at some of the reasons why. So why is the patient pushing the partner away? Is it because of pain? Is it because of body image issues? Are there ways that we can help the patient feel better so that the pushing away isn't happening? But we really have to have counseling and good communication for that to happen. Yeah, and then, so those are all the questions, I think. So yeah, thank you, Erin.
Yeah. Oh my gosh, thank you so much. That's great. Yeah, again, if anybody has any questions that come up, please feel free to email me, and I can pass them along, or to email Rianne. Thank you again, everybody, so much for coming out, and thank you so much, Rianne, again. That was such a great presentation, and we really appreciate it.
Welcome. Yeah, have a great day, everyone, and thanks for being here.
Thank you so much.